morning, and thank you for creating time for us this particular morning as we begin our health segment on this Wednesday. Yesterday, actually, we were marking the World Diabetes Day, and a lot was said. Actually, this whole month has been dedicated to creating awareness around diabetes, and we just want to talk about the country's progress in managing diabetes and also sort of use this platform to create awareness for you to be able to know what are some of the risk factors, what is it that you should be able to do to take care of yourself in case you're not part of the statistics yet, or if you are somebody who has diabetes, what is it that you need to do to be able to better take care of yourself even as you continue managing it. And I have a panel of two gentlemen who are going to be helping me dissect this particular subject. I have on my far right Dr. Daniel Katambo. He's a consultant physician, and of course he has quite an expertise on matters diabetes. Also, he'll be talking to us about type 2 diabetes and whether it can be reversed and what can be done to be able to do that. We also have in studio Dr. Paul Ngugi from the Nairobi Hospital. He's also a consultant diabetologist and also has a wealth of knowledge on matters diabetes, has been pivotal in a lot that has, helped this country take steps to better manage this particular condition. And we have this gentleman in studio with us to unpack this subject for us. Thank you so much. Should I say Madaktari? You know, it's rare to have a panel of Daktaris in studio. We appreciate your time this morning. We're talking about diabetes, and one would ask themselves, looking at the trends, having observed where we are going, you can just contextualize it to our Kenyan context. How big of a problem are we talking about this particular morning, even as we create awareness? First of all, let's begin from where it starts. Let me start with you, Daktari.
Thank you so much for having me this morning. It is my pleasure, and I also have to honor Dr. Paul Ngugi. He was actually my lecturer, so we've come from afar.
Great.
So diabetes as a condition has been on an alarming increase over the years. I remember when I was in campus, the year 2000, the numbers were quite low, but right now we are talking about prevalence rates of about 3.3 to 4%, which is quite an alarming number. And of course, the type that is mainly on the increase, or the one that is we are seeing more on the rise, is the type 2 diabetes, which is associated with risk factors like sedentary lifestyle and also our foods that we consume.
All right, Dr. I'd also like to hear your thoughts on this scene. He's talking about an alarming trajectory of a surge in the cases of diabetes. We had this even from the CS who spoke during marking the national celebrations to mark diabetes. Just to quote a bit of what she said, she was actually disclosing that more than 2.1 million Kenyans are diagnosed with diabetes, with only 40% currently under treatment. Looking at this disparity, and I'm a bit concerned, should we?
Thank you very much for having me. I must re-emphasize that it is an upgoing trend. I remember one time, I think in 1954, I think it was one case that was described in Kiambu. But even as we talk about 4%, we must see at the spread of the country. There are counties in this country that have more than 4%, because you find diabetes being restricted in what we call is the counties that are more urbanized, more settled. And you find the Mount Kenya region, the Kisii Highlands, the Taita Highlands, the coast, Nairobi, and all major metropolis, the incidence is certainly more than the 3%. Then, as it has gone up, it's gone up all over the world, other than the developing world, the first one where it seems to be going backwards. And that's why we keep on saying that diabetes now is a disease of the rich and affluent in the third world, and of the marginalized in the first world. And it's from what Katabo has alluded to. The lifestyle in the developing countries, the affluents tend to be lazier, sorry to use that word, taking excess calories because they can afford it. In the first world, the affluent tend to eat salads. Of course, I think healthy eating, and since they're educated and they get the public health. So there are challenges, there are steps that we have made as a nation It's not so long time ago when we didn't have a desk dealing with non-communicable diseases in the Ministry of Health, and it took the UN intervention to have every country have an NCD, so the department. And diabetes does not come alone. It comes with diseases like hypertension, obesity, and heart disease. And all these diseases eventually, the end game is to cause cardiac death and severe complications. So it is alone may be seen much, but also the hypertensions of this world are also going up. The heart diseases are going up, and they are all conjoined. They're conjoined twins, so to say.
So we are talking about diabetes and the complications related.
It comes with what it comes with. Yes, yes.
One thing you'd be surprised to know, I think, something that I think all of us should be concerned about is the numbers of the people who do not even know that they have diabetes. What they think they have are just those complications, only for them to go to hospital and discover that they have diabetes. And I want us to talk about what diabetes is, because we may assume that this is a conversation we've had over the years, but as we create awareness on what diabetes is, let's address that population that maybe could not even be knowing what this condition is, or they could just be having it and they don't know. So from a simple way of describing it, diabetes is a condition that is related to blood sugar, but I want you to just expound to us for somebody to be able to understand, and even the types of diabetes in just a simple...
Yeah. So as you've said, diabetes is a Greek word that means sugar. It means that your sugar is up. Now, when you look at what causes your sugar to go up, actually is the reason for classification of diabetes. So when you're classifying diabetes, you're sort of like looking what is causing the diabetes. So in all the conditions that we call diabetes, the sugar is up. But when your sugar is up, because your pancreas is not producing enough insulin, then that is type 1 diabetes. And when your sugar is up and your insulin is actually in excess and not working properly, you are having hyperinsulinemia, and you have gained weight over years, then you get what you call type 2 diabetes. If you get diabetes during pregnancy, that is called gestational diabetes. If you have a problem with the organ that produces insulin, that's the pancreas, that is, you can get now secondary diabetes. And this can be injury due to many other factors. You can get trauma where you have been injured to the pancreas. You can get injury to the pancreas due to alcoholism. You can get injury to the pancreas due to stones in the biliary tracts. So there are many other causes of diabetes, and I'm forgetting another main one, especially drugs. The drugs we use can also be used to cause diabetes. So the word diabetes cuts across, and what causes diabetes is what we use to classify.
The categorization.
Yes.
All right, so here we try and make it as basic as possible. Daktari, when you talk about insulin, I want you to talk about also, for somebody to understand, what insulin is and how that also, when it is in high levels in the body, how does that affect the system? So
insulin is an hormone that is produced in the pancreas. The pancreas does many other functions, but one of the main functions that it does is insulin production. Now, when does insulin come in? Whenever you have sugar in your blood, the pancreas detects that there is sugar around. Now, sugar, when you have sugar in the blood, it's almost totally useless without insulin. So the pancreas detects that there is an increased amount of sugar, or there is sugar in the body, and therefore the pancreas produces insulin, so that you are now able to use the sugar for functions. Either you are talking like the way we are talking, either we are running, or either we are jogging, or any other activities we are doing. But when the sugar is now in excess, the pancreas also produces insulin in excess. And this excess insulin and the excess sugar now results in deposition of the sugar in form of fat in your body. And it starts from inside, where it goes as inside the liver, the pancreas, what you call the visceral fat, and then now starts to come out over the years. But as you do that, because this organ, sort of, to use a very layman language, is as the sugars continue coming and you're producing a lot of insulin, the pancreas sort of like gets tired, to use a word, and therefore the production of insulin goes down, but the sugar is still up. This is when you develop type 2 diabetes.
All right. Now you understand. And I want us to talk about, Doctor, he has talked about the categorization of diabetes depending on what causes it. Looking at the trends and the people who you interact with on a day-to-day basis in terms of the patients, what category do you read that is a bit concerning from the numbers that are presenting that particular type of diabetes? And from your assessment, why do you think that type of diabetes is becoming a big problem?
Thank you very much. Just to recap what Dr. Katabo has said, there are two types of diabetes, majorly. The type 1 that occurs in children from the age of 6 months upwards to young adults of the age of 19 years. But there is an overlap. You can have type 1 occurring between 19 and 35. But mostly people get diabetes at early childhood and teenage will be type 1. And those people with type 1 have what we call an absolute lack of insulin. They lack insulin. Their pancreas are not producing insulin. And then,
so they have to be on insulin
they're like from the word go,
Yeah.
And the cause of diabetes in this age group is various. It is thought that the pancreas or the beta cells that produce insulin are destroyed by what we call antibodies. Basically, these are chemicals that the body produces to fight infections. Those are what are called antibodies. But the body develops antibodies against itself. And there are many diseases of that kind. And they destroy the pancreas. And what's unfortunate about this age group, this diabetes, is that its manifestation is very dramatic, almost critical. These children will present in coma sometimes, what we call ketoacidotic coma. And they may die even before diagnosis, especially in the old days when we were training, they could die because people had diagnosed them as malaria. And, but later on, when they present, then it's treatable with insulin. And I think I want just to give hope to people where their children get diabetes, that people are treated, and they have a treatable, and they have a productive life. They mature, they have families, and they go to college. And some of them play football, and some of them run marathon, although they don't break the record, but they do participate in what's called a normal life. So as long as the insulin is given. And that group is not so much in globally. There is more of those type 1 diabetes in the cold countries, although we have our numbers here. Maybe about 4 to 5% of will be in that group. The other group is the type 2. But the type 2 will come, is used to be called adult onset. But with the lifestyle changes we have seen with people eating, in quote, better food, that's hyper sugar, hyper fat, fast food in all these fast food eateries, and drinks that are commercially prepared with a lot of sugar. We have kids from the age of maybe 8 getting this so-called type 2 diabetes. I just want to just add to what Katabo said about the insulin. He said insulin opens up. And I like the viewer to imagine a key and a door. You have a key that opens that door. If we did not open for us inside, we will still be outside there. So insulin acts as that key that opens the door for the sugar to enter, to go and be burned as fuel. Sugar is our fuel. When we sit here, when we walk, we use sugar. And all the organs of our body, other than the brain, require insulin to open the door. So when it doesn't open the door, the sugar remains stranded outside there. And then when it remains stranded outside there, your body has to get it out. And that's why the commonest presentation of diabetes would be urination, getting thirst, because you're trying to get away the sugar. And as you know, because it's a fuel and doesn't get into your body lacks energy. It's like you have fuel in the tank of a car, but it doesn't go to the engine. The car will not have energy. That's one of the commonest signs, and that's one sign that people ignore, is the so-called fatigue, tiredness. Even before you understand why you're urinating a lot. You've started getting tired earlier, you go home, you can't listen to the news, you're dozing. And that was not usual. And that's a nary sign that you must. And the thirsty, then you say, quench. And what's common that ladies tell me, I'm drinking a lot of water to lose weight. And they're losing weight. But when they're losing weight because they have diabetes. They're losing calories. But they have been thinking that drinking water is because they saw somebody say drink water. But they've been drinking water because they were thirsty. So you drink a lot of water, urinate, you lose a lot of water. And then another sign that will occur at that time is poor vision. Again, because you've lost a lot of water, your eyes shrink, you're not able to focus. And you find again, you're asking, can the TV be brought in here? Or so because you're not seeing well. So there are those signs. But critically, there are those two differences. The complication would be about the same. But again, this type 2 diabetes, because it doesn't come like as dramatic as type 1, you can have diabetes for a long time before knowing.
Without knowing.
Many a times, especially from the rural countries, people present with a leg that's rotting, a very bad infected wound, and they'll get even amputation from the word go. But all this time, the reason that wound has been festering is because they have diabetes, they have poor control to infection, and can cause even mortality. They can present even severe complications of diabetes without knowing. 20% of them can come with eye complications from diabetes, beyond diagnosis. People think it's a benign disease, but it's quite malignant because it starts early without warning. By the time it manifests, and again, you notice the symptoms are urination and drinking water. If you have a lot of water to drink, you may not think urinating is a big issue. If you're losing,
think it's healthy, you're going to the bathroom because you're taking a lot of water without knowing that.
And if you've been obese, and you find yourself losing 10 kilos, you say, is that walk I've been doing? Is that walk I've been doing? But you've not been doing enough exercise to lose weight, but you've lost weight, and you think it's good, so you keep on losing weight. Just one time, one person came to see me. He thought he had HIV. He was scared of seeing another doctor because those were HIV days. And we tested his sugar was very high. And when he managed the sugar, he gained weight, although not back to the obesity. But I'm saying it's loss of weight on its own without you having done enough to lose weight is also a sign that can tell you there is a problem here.
Yeah. So the type 2 diabetes is the most common?
It's the most common, yeah.
It's the most
About
common.
90%.
90% present with type 2 diabetes. Yeah. But type 1 is most common in children?
Yes.
But you're saying there's a trend that is showing that type 2 is also beginning to...
Young children are getting the diabetes of the elder. And the parents or whoever has, it's a much more... When it gets in children, it's much severe disease than when you get it in adulthood. Because to avoid because parents of these children, they will panic, they want to find alternative treatment for it. I'm just trying to say that when your child, whether teenager or pre-teenager, is diagnosed with type 2 diabetes, it must be treated aggressively. Because, one, remember this child has many years to live. Because if you're a child, if you're 10, maybe you have 60 years to live, or 70. Now that gives the chance of diabetes messing you up. So from the word go, they should insist with their doctors that they want perfect control, as perfect, near perfect to these children. And because they are the ones in charge, they're the ones to, not to fear, but to hold their children's hand, to good diagnosis, good treatment, and set goals with their physician as to how they're going to go around it.
All right. There's also something I want us to talk about, and this relates to family history, things like ethnicity. There's also concerns about history of gestational diabetes being a risk factor. That people find maybe their child or themselves having diabetes and they ask, where is it coming from? I think I've been living a healthy life, and just help us understand the nexus between those issues and risk factors that cause diabetes.
Yeah, thank you for that question. So there's definitely a genetic component to diabetes. But again, when you look at type 1 and type 2, as Dr. Paula said, type 1 diabetes tends to be more of an autoimmune condition. And yes, it can run within families. So you can find, like, if you have a twin brother or a twin sister, then if one of them has diabetes, then the other one has a higher chance of developing diabetes. Type 2 also tends to have a genetic component. However, I think, as you have said, many people would say, how come in my family I don't have diabetes, and yet I'm the only one who has diabetes. And most of the other times, first of all, we have to recognize that testing genetic, predisposition can be very expensive. But what I usually tell patients is that in as much as you have diabetes, the greatest contribution is usually lifestyle and sedentary lifestyle, and the foods that we eat. So in as much as there is the genetic component, we do not really want to put it out there as the major cause of especially type 2 diabetes.
All right, but then there's always this concern of, whether this issue is treatable. Dr. What can you say about that? We were talking earlier and we were saying it's not a death sentence. Is it treatable? Talk to us about the treatment options and what somebody should expect in the treatment plan.
Diabetes, both types of diabetes are treatable. I think the word underlined, it's treatable. And the two physicians, there's a physician who stays on this side of the desk and the other physician who stays on the other side of the in a consultation room. That means the patient and the doctors are equal contributors in treating this diabetes. And in equal measure, I must reinstate, and Dr. Kalabo maybe will talk about that later on. And he mentioned that the major contribution for diabetes is lifestyle. And those people who ask why I have diabetes alone, the first person in the family, I always tell them they are pioneers. When I was growing up, diabetes was hard on the teachers' homesteads, the truck drivers who had more equity homesteads. Because those people had more money, there were calories intake. And as we grew older, you found diabetes came into families whose sons and daughters went to university, they came to Nairobi, they're able to take them goodies when they're going for Christmas, or every weekend they go, the chumi shopping is big. So the calorie intake contributes a big issue. Now, coming to what, and then maybe something else that you asked, maybe I need to mention, because it's very important, the gestation diabetes. Because I think it's something that it's on the high now, young ladies when they're pregnant, getting gestation diabetes. And it's meaning because we have people when they're diagnosed with gestation diabetes and it's managed very lightly and they will deliver. But what I like to tell patients or people with gestation diabetes, it's a warning that you're likely to get diabetes, either in the next pregnancy or outside pregnancy. So the fact that you sugar normalizes after you deliver does not mean you're out of the woods. It means you've been given a chance to go and change your lifestyle, to go and eat well, to go and exercise. So eating well and exercise. And what does eating well? Again, I'm not a dietitian, but I know eating well is eating healthy food. What is healthy food? The healthy food, I think mankind has interfered a lot in the food we eat. In terms of, and it is not for bad reason. I think it is an issue to fight famine and hunger. But we forgot that why do we have an energy biscuit when you can have ugali, for instance? Why do you, person who is busy in the studios, have to have a bar of chocolate? To
keep you going.
To keep you going, and a bottle of Coke. Why do you have that when you could have had maybe an apple or fresh fruit? And that's what I'm trying to say. And perhaps is a really so diet is very important. Healthy diet. But also the food we eat. When I eat breakfast, because I can afford it, then there'll be maybe toast, there'll be cereals, there'll be eggs, there may be some bacon, all that. And then I'm going to get into a car in the garage that is in the house, drive to the office, sit on a swivel chair, move backwards, this way. And in the evening, and at 10 o'clock, have tea and biscuit.
And sit and watch telly.
Sit and watch telly. People do not know why we eat food. And I want to submit here that we eat food to give us energies for growing, for surviving, and for everything. But our body does not have the capacity to store. And we think the reason we store too much, because people say that during evolution, people who were able to store food survived the famine. But nowadays, we don't have famine. So we do not need to store much. So we are eating excessively. In whichever format you look at it. More than we need. More than we need. Our children, we are feeding them excessively. And even even as you grow older, we're eating excessively. So we need to look into diet. And you need to seek always seek counsel from people who are qualified. Then exercise. What exercise do you do? And this way, I think both the government and the society plays a role in terms of exercise. When we stack up flats in an area, and you've seen the way flats are built in this country, wall to wall. There is nowhere, even if you wanted to jog in your neighborhood, it's difficult.
There's no space.
There's no space. When they build roads, they never leave space for walkers or for bicycle riders. When do we expect our people to exercise? The gym, who can afford a gym? Man was created to walk and run where he can. So we should perhaps, as a community and as a society, because prevention is better than cure, we start teaching our people to exercise from childhood. Many times when I'm teaching students, I ask them, do you exercise? The whole class has said, no, they don't, and nobody exercises. Oh, I can. One of them jokes. But even young people, don't wait until you get diabetes to do exercise. Prevent your getting diabetes by exercising. For people with diabetes, personally, and the elderly, like people who are senior like us, we say if you can put 200 minutes per week minimum of good exercise, maybe 40 minutes or 30 minutes of rigorous exercise that makes you sweat. Even younger people, it really works. It works well. And it will help control weight. It will help consume the excess calories that you're storing up. It will help your muscles open up for the sugar to enter and the insulin to work more efficiently. Because Dr. Katabo alluded the issue of insulin resistance, that your body is not using your utilization of insulin very well. Yeah. Then the other treatment, you mentioned the diet a little bit more. I will mention briefly on medication. This is a very dynamic field, and it's evolving. It's evolving. Let me put it, it's evolving. But suffice it to say, there are two groups of medication. There will be the oral medication that they are newer coming up, very advanced, that help. But when you choose medication, and this is the thing to the patient, is that when they're discussing with their doctors, other than bringing down the sugar, these days we want to use medicine that also helps protect your heart and your kidney. These are two organs that diabetes destroys and kills you through. So the medication and even the diet you're using should be favorable to those two organs. So as you choose medication that has been known to benefit the heart and the kidney. And then the other thing important before I finish is the issue of targets. And this is a discussion that patients should have with their doctors. The doctor should tell the patient, my target, our target, not my, our target, me and you.
So it's a team.
It's a team effort. Our target, is to have fasting sugars below 7. If you find you're not achieving that target, even if it's not your appointment, come and force me to discuss it with you. Our target of sugar after eating should not go above 8. And these are your figures. So it's not an example. These are your figures. That if you do random sugars, you find it's above 8 and 10, then you need to have a discussion with your doctor. And then there's another test that people must do every 3 months called HbA1c. HbA1c.
This is for everyone, regardless of...
people with diabetes.
All right.
This test helps you know the summation of your sugars within the last 3 months. So even if you're not able to see the doctor, if you go to see the doctor in 3 months, then he does HbA1c, he will tell you, go here, your sugar is not very well done. Even if that sugar, because what people sometimes do, they will fast when they're going to see the doctor. They will fast very nicely. And they come to the doctor, the sugar is so good. And then the doctor will say, good, let's continue. But if you did HbA1c, they will find those out and tell them, no. Even if this one is good, overall you're not good. Let's see where the problem is. Where then you go back to the diet. If you have a dietitian in your office, send to the dietitian. If you're the only dietitian, you are the doctor and the dietitian, go through the diet of the patient. And perhaps you pick where they're going wrong and then look at the exercise, the rogs, where they're doing, and then you'll be able to guide them. Now, tablets will fail. And I like this to underline that once you start treating with diabetes with tablets, the type 1 you use insulin, that there's no other way you use insulin. Once you start using tablets, in 5, 10 years, sometimes people go to 20, the tablets will start not delivering the result. And how we do that is that if you, as a patient, see your sugars are going up or your HbA1c is going above 7 and you're using the maximum number of drugs, those drugs have started failing. And you must then move over. Because when you progress to the next level, you avoid getting complication. And the next level is insulin. So even people with type 2,
at some time
they'll use insulin or some form of injectable. There are newer drugs other than insulin because we don't have them in the market yet. But when they come, then you must move to the next level.
All right. I want you to also weigh in on that. You speak you've come out in public and you're really championing for the reversal of type 2 diabetes. Just to add on what Dr. has said and what needs to be done, one thing I'm getting here is that it's actually a team effort. It's something that cannot be achieved by just the doctor alone. Even the patient has their own share of responsibility in making this work. In your line of work and even interacting with patients of diabetes, what is it that you have identified that really works to reverse type 2 diabetes?
Yeah, so to focus on type 2 diabetes, as we've put across, it's a lifestyle disease, right? And so therefore, it only makes sense that we study our own lifestyle and how it is, and then change it to manage it better. So when I will now just take you back to how I explain what causes type 2 diabetes. It's the exposure to the sugar that leads to production of insulin, and that chronic exposure and a lot of insulin results you in, over the years, gaining weight, and eventually you develop insulin resistance, and the production of insulin goes down, and therefore you develop diabetes. Now, when you look at that whole situation, it means for you to manage diabetes using lifestyle, then you need to reverse the same. So what do you need to do? Take foods that are converted less to sugar, and therefore that will ensure that a lot of insulin that you are producing now is even coming down, therefore managing insulin resistance. And therefore, if you manage the sugar that is coming in and you manage the insulin resistance, now we start to see you losing weight. And one of the biggest indicator of lifestyle change is weight loss. And of course, not the pathological weight loss that Dr. Paul has mentioned here. Now, the physiological weight loss, where you lower your sugars, the insulin goes down, and therefore now your body starts to lose weight. And remember, the weight was actually a form of stored what? Sugar. So therefore, when you lose weight, you see yourself managing the diabetes much properly. Of course, there has been the school of thought of many years of how we've managed diabetes, right? If you look at the three basic or macronutrients that we consume, we have the proteins, we have the fats, and we have the carbohydrates, right? Now, Paul mentioned very well, and he said, we have engineered foods. But if you look into the market, which foods have we actually engineered the most? We have engineered the most the carbohydrate food. We have a lot of refined carbohydrate, meaning the moment you just take them, they are just converted to sugar, and there you go, you pump in your insulin, you gain weight, and you have diabetes. But how much have we engineered with our vegetables, and especially our local vegetables? Have you heard about maybe a fast food selling vegetables? Have you had a fast food that has really, really engineered the proteins? You will find the ones that have been engineered are like maybe the sausages, the bacons, and the rest of the stuff. But we haven't, when you look at the healthy foods that are not converted to sugar, because out of the three macronutrients, when you look at who pumps your sugars the highest, it's the carbohydrates that you consume. And then the next are the proteins, and the last ones are the fats. So if you look at it from the last 50, 100 years, when you developed diabetes, we used to say, oh, because you have developed diabetes and you are overweight, you need to avoid fats, which is correct. However, I've just illustrated to you, as long as you're taking healthy fats, the healthy fats have the least of the impact in terms of your sugar levels. And then the next food category that has the least of your food impact are the proteins. And therefore, the other one now is the carbohydrates.
So it's the carbs that we should be concerned about.
Yes. So if we focused on lowering our intake of carbohydrates, and especially at the preventive level, you will find very few people developing diabetes.
All right, all right. I want us to talk about, as we are marking, the awareness on diabetes force, I think it should be some 3 years, from 2021 to now, 2023. The theme has cut across to center around access to diabetes. The World Diabetes Day from 2021 to 2023, the theme has been focusing on access to diabetes care. I'm concerned about the numbers I shared with you earlier when our CS was revealing to us that 2.1 million Kenyans actually have diabetes, but only 40% of this population are under treatment. When we are looking at access to diabetes care, comprehensively, what does it look like from where you sit, Daktari? And are we privileged to be in that space as a country? Where is the rest of the 60% who have diabetes?
I think we have moved very well, let me put it that way. I was practicing diabetology when we used to be like one doctor in KNH looking after, sometimes you're seeing over 200 patients on a Friday afternoon, and then you book them to see you after 6 months, if you're lucky, up to a year before the patient is able to see another doctor. Most of it to have seen kids, people are turning teenage without developing their sexual development at the age of 18 because of bad control. So where are we now? And what does access to good care for diabetes mean? We have been on a journey, and me and Katabo, we belong to another organization that has been doing a lot of that, public awareness. But most important is to avoid or to restrict, not to restrict ourselves to diabetologists. It takes a long time to train a diabetologist. And what we have been doing, we have been having centers of, is it excellent care? Centers that we have people who are trained, especially in the lower cadres of health staff like nurses. So we have in Mombasa, Nakuru, KNH, we have many centers now that are overseen by a doctor, but have trained very competent nurses. Where I trained myself outside the country, clinics were being run by nurses, doctors just came one. So we have many of those people we can train, and we have been training them. In our organization, the study group and the DMI, we have been training nurses. I think what's important is now the ministry to formalize what we call the specialization categories outside the doctor limb, so that we have, the problem has always been a nurse trained as diabetes is not, does not get the priority in promotion of the lungs because they're not doing what is called standard nursing care. So because we have many categories, ICU nurses, renal nurses, and maybe hypertensive nurses, all those groups, and then we have this cadre of health staff also called clinical officers. That can be very useful in terms of making access, health accessible. But having said that, that's personnel, and I think we are on the right direction. What we think is, what is important is for the ministry itself and the government itself to invest. Most of these health centers, most of these clinics, while it's seated by an initiative from individuals. We started one with a colleague, one of the first nurses we trained, Mrs. Mwangi, who died later on. We started the first nursing diabetes clinic in KNH in 1995, somewhere thereabout. And thereafter, been going up. So I think the ministry should recognize those types of clinics because it will benefit patients with diabetes, hypertension, obesity, adolescent issues. All these are issues that will be a burden to the society. So I think that is important to train more and to start them in a formal way. So it doesn't leave it to NGOs like the DMI, KDSG to do it, so that we have curriculum in KMTC, post-basic diplomas to be done in specialities, other than the old specialties of ENT. There's ENT and ophthalmology has cadres that have been trained below doctor level for a long time, and even pediatrics. We need to understand the disease that are killing our people now is not infection anymore. It's these lifestyle diseases. So we need to start. So
advancing our training and even investing in having more training coming from the government side.
Then the last one is availability of quality medication. And here, my passion is young people, the people who need insulin. Because that's where the problem is. Because you have a child of 10 or 8 who develops type 1 diabetes. You want that child to finish school, to get a job, to get married, to have children, and to progress. So that means the burden to this, the community is much more than a type 2 who will get diabetes at the age of 50. This needs, what do you do to their school programs? The availability of insulin is a very big issue in this country. I don't think it has improved. Because we have insulin that is available to our society that is not being used anywhere else in the world other than in the third world, that does not allow you to get good control. So you have kids dying of early complication kidney disease when they're pretty young. The ones who get the type 1 in the cities, perhaps their parents are able to afford treatment. But at least the availability of insulin should not be something we should be discussing in this age again. We shouldn't. We have situations whereby insulin itself, one vial, the bottle that contains insulin, is costing, the ones in the government may be costing up to about 800, and depending on the dose you're using, you could use more than that in a month. That's quite expensive. And if you don't have insulin and you have type 1 diabetes, you miss insulin for 3 days, you're going to die. It's as bad as that, because you get ketoacidosis and then complication. There's nobody to treat you in the villages. You just pass on. Then the issue of meters, testing meters. Again, now we have pharma out of its good, it's good heart. It's offering meters, but also with the caveat, I offer you a meter, then you buy my strips. The society should be able again to offer patients with diabetes meters so that they can always be tested sugars, and they know in real time. Now we have this card that has been launched by the president the other day of those people who go to the villages. Those people should... The community health supporters? And it's a very noble idea. But that person should go and find a patient with diabetes, be able to go and look, let me see your meter. These are your sugars. Because the meters these days have capacity of recording. Then they can be able to tell them, now these sugars of yours are not good. Do this, then go and see the doctor. So all patients should have meters. I'm sorry to say this, but supplied by the health authorities. So all patients with diabetes, they have meters that are upgraded as and when needed. All right. I also want you to weigh in on that. What does a comprehensive access to care look like for a diabetes patient, and also address the burden of cost, because that has been what is killing a majority of those who cannot be able to access treatment. So actually I wanted to make an addition to what he was talking about, and that was the issue of cost. Remember, he has alluded that there is this type 1 diabetic patient who is 6 years old, right? This patient needs insulin every day. Now, we are both directors, as he said, in an organization called Kenya Diabetes Management and Information Center. We are lucky enough to foresee a program called Changing Diabetes in Children that is sponsored by NNF, which is World Diabetes Federation and Novo Nordisk Foundation. They've come and they are able to give us insulin, and we are also able to get glucometers and some strips. This means that we are now able to get insulin. But as he was talking, Dr. Paul put it, the insulin we have is not the best that these children need to be on. Now, the best of this insulin that they need to be on costs like $1,400 per month. The glucometer itself, if they were not to get it from the CDIC program, then one glucometer machine can cost up to even 3,000. The strips themselves can be 2,000, 3,000, 4,000. Now remember, these children, their diabetes is not well controlled, right? So they tend to develop complications. Now let's bring in the cost of professional treatment. He said there is complication to the eyes. Now, when you have complication to the eyes, means you have to go to the hospital and visit an ophthalmologist. A specialized doctor? Yes, you have to now go to an hospital and visit a nephrologist if you're having a problem with your kidneys. If you're having a problem with your legs and you're having neuropathy and probably an amputation is coming in, then we have to involve the surgeon.
Well, if you look at just the cost of dialysis by itself, one dialysis one episode of dialysis is about, I think NHF pays, is it 5,000, 6,000? And then you have to come in and pay another 5,000. Now, if you look at that cost, and this is a child that you want to survive for 70 years, most of them, their lifestyle is significantly reduced, unfortunately. And that's why we have to call on the government and the policymakers to reduce the cost of managing especially type 1 diabetes, because this is a need. These children need insulin. It should be offered for free in all our county or dispensary or our hospital. The monitoring devices, we either call on the policymakers to lower the VAT or make it almost zero so that these are available to these kids, and the management of them becomes quite effective. If you look at a government like the UK, the management, if you have type 1 diabetes, is actually free to be managed. And they are so advanced that in terms of technology, they have devices that can detect how much sugar is there, and they deliver the insulin. I'm not saying we can get there, but the little we have, if we can waive the VAT, make sure that the instruments of management of diabetes comes down, that would really help in type 1 diabetes. Now remember, when you look at this patient holistically, let's not forget that they suffer from a condition that they are going to live with for a very long time. So you can imagine the burden in the families. You can imagine the level of mental health issues that you will come in. That is the one thing that we tend to forget. More than 30% of people living with diabetes, in one way or the other, the caregiver or the patient themselves are suffering from depression. And therefore, we need to be looking at it holistically so that we have the health centers, we have psychological people, psychologists who can deal with mental health issues. Schooling for these kids also becomes an issue, because if today you injected yourself and you got a low level of sugar, therefore you get an hypo episode, maybe your caregiver becomes concerned and they don't release you to go to school. Tomorrow, we don't inject you, or the insulin did not work properly, and the sugar now is up, and now you have to be admitted due to DKA. So there is a lot of creation of awareness that really needs to go out there and to support especially type 1 patients living with type 1 diabetes.
All right. And as we're just about to wrap up this conversation, let's talk to the different cadres of the population. What would be your clarion call, Daktari, to those who do not have diabetes and those who have diabetes? Then you'll talk to me about what you hope would be your clarion call to the government and the policymakers, so that we know how best to move as we manage diabetes in
My clarion call is to the society, because Dr. Tambua said that perhaps if we did it correctly, we would cut down the incidence of diabetes. So I think everybody of age from childhood, because the way we invest in children is the way they're going to be as adults. Encouraging exercise and good eating from the word go, Those young parents, when they feel they have money to buy pizzas, perhaps they can make a pizza at home that is healthy. There is something like that.
And there are ways to do that.
Yeah. If you think your children need a milk thing, can you perhaps train them to be taking glasses of milk instead of insisting milkshake? Sorry, of all those sort of milkshake is very nice thing. It is very nice. But that's not what you keep in your house. The things we put in our fridges must be very important. Do you put sodas, or do you put fruits in the fridges? That's very important. Then exercise. Parents must show their kids how to exercise.
All right.
For instance, if you have young children, and I don't know whether you have young children, when they go to pray, go and pray with them. Take them to Karura Forest for a walk. Walk with them. Show them that riding a bike is more important than the remote control, because that's another gadget that's going to come, and it will pay dearly. We have the remote and the games. They're just sitting on the sofa and drinking or eating nice things, and they're not doing anything. take away those smart things from them, or have regulation of those smart things.
Thank you so much. 30 seconds, Dr.
Yes, so my clarion call goes to the government and policymakers. Please, let's make sure that management of diabetes is lowered as much as we can in all the households, and especially for type 1s. You can imagine if you need insulin and you do not have it, that means that tomorrow you will develop hyperglycemia or high sugars, and you get into DKA, and unfortunately we lose these kids.
All right.
We also need to make sure that our policymakers are aware that the management of diabetes requires gadgets like glucometers, like strips, like lancets. And we ask of them to consider either zero rating these gadgets so that we have access to them, and they be distributed for free, and especially to those people living with type 1 diabetes.
Thank you so much. Dr. Daniel Katambo, he's a consultant physician. I was also having this conversation with Dr. Paul Ngugi, a consultant diabetologist. Thank you so much, gentlemen, for creating time. There's much that I know you have learned, and now you know that it takes your own responsibility to be able to better take care of yourself in case you are battling diabetes or you are not yet there yet. All of us have a responsibility to play. Thank you so much for watching Daybreak this morning. My name is Afina Cheng Oma. Have a lovely day ahead.